Once you've understood the kinematics of correction by Ponsati's method, the whole process becomes very simple. So you have do's and don'ts. Remember, the devil is in the detail. It is a specific method of manipulation. It's a specific method of casting. It's a specific method of tenotomy. It's a specific method of bracing. It's a specific method of looking for recurrences and management of recurrences, and a specific method for follow-up all these cases. So you have the specificity as important. So we have seen it in the model. In actual child, we have to remember where the landmarks are. So there are two kinds of manipulations that we do. One is the two-hand manipulation. The other is the single-hand manipulation. And you have to be adept with both the techniques. In a given child, you will use both. You start with the two-hand manipulation. So how do you do it? Casting has to be done when the child is comfortably placed. Best place for the child on the surface of earth is in the lap of its mother, preferably breastfed or recently fed with milk. You start the manipulation by Ponsati's technique at the foot end of the mother's presence. You need the caster on one side, mother on one side, and the manipulator on the other side. So you need minimum of 3 people for a casting. The hand placement is critical. The hand position has to be learnt and practiced. So let's practice once. The child hold the leg with the fingers on top like that. Feel for the lateral malleolus, and in a small child 1 centimeter in front. This is a bigger model, therefore it is further away. 1 centimeter in front is the head of the talus. Feel for the head of the talus. Classical Ponsati's maneuver uses the index finger alone. At the medial plantar border of the first ray, whole ray, elevate it to supination and abduct it. How much force do you use? Do you use a lot of force? No. If the hand is like this, and I want to correct the resting position of this hand to the limits of its range of movement, it will go like that. That's okay, no pain, nothing. But if I push it, there will be pain. Pain indicates there is some damage happening inside to ligaments inside. You don't want that. Tear of ligament causes scarring. Scarring heals by fibrosis. Fibrosis shrinks over a period of time. So if you forcibly manipulate, there is a recurrence of deformity. It has to be gentle manipulation. So what do you do? Again, same technique. Feel for the lateral malleolus. Go to the fulcrum with the index finger, or as Dr. Shafiq Purani taught, elevate the first ray with the middle finger and abduct the first ray and the whole foot with the index finger, using the thumb on the head of the talus. That's it. Now can you put a cast like this? No. So what do? You slide your thumb back, you maintain the position, keep sliding your thumb back and hold it there, and bring your finger back. Now maintaining the position of the foot, all right. In this position, you hold the foot while the caster puts the cotton, and on top of that, the plaster bandage. As soon as the plaster bandage is unrolled below knee, not above knee, it has to be put in 2 stages, below knee. As soon as the plaster is put, you will then use from the 2-hand position to the single hand position. The single hand position needs to be done and learnt and practiced. So I want you to hold this like this. If I were to use, I was on a 2-hand position, elevated, abducted, held back like that. The caster has put the cast, and then I am molding. So I move. So what do? I switch my thumb to the head of the talus and I switch my index finger like that. So that's the single hand position. Thumb on the head of the talus, index finger beneath the first ray, raising it into supination and abducting it. So this is the right hand doing the single hand maneuver. So with this hand I am molding beneath the lateral malleolus, behind and above the heel, and I switch this hand index to thumb and thumb to index. Position is maintained. Now again manipulate and I do the molding there. Not manipulate, I mold. Then I again switch index to thumb, thumb to index. You don't take away your finger until the thumb comes into place. Index to thumb, thumb to index, mold, 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 mold all around. Index to thumb, thumb to index, mold, mold, mold all around. So the two hand position, you start off the manipulation and then switch to the single hand manipulation. Some people like to do this manipulation technique 4 or 5 times and then go on and do the casting. Some people just straight away go to the manipulated position that is corrected and do the casting. Either way, no force, only maintain the thumb on the fulcrum, the head of the talus, and the manipulation always with supination. The commandment that Ponseti gave is, thou shalt not pronate, because if you pronate the foot, it doesn't correct, nothing happens to the correction there. If you supinate and abduct, correction happens. If you pronate and abduct, no correction happens. Similarly, if your thumb is placed wrongly on the calcaneum, and see what happens, you prevent the normal kinematic coupled movement. So what happens? If you try to correct, no correction happens. So you may have any number of casts, but correction will not happen. Once you've done the movement of manipulation and the casting has been done in the foot, make sure the cast reaches till the plantar surface of the toes. The dorsum of the toes may be exposed, but the cast should expand to hold all the toes into a neutral position at least. Should not be left free. The toes have to be supported by the cast. It has to be supported by the cast. Dorsum may be cut back a little bit to free the dorsum of the toes. That's the first part. Molding has to be good. That's the second part. Your end of the cast should be left as a bump so that you can take off the cast by wetting it in a basin full of tepid warm water. Cast must be extended above. It is a groin to toe cast. If you don't put a groin to toe cast in a child with severe equinus, the cast will slip out. And if it slips out, equinus will become worse. And the cast has been very clearly shown to have holding power for this abducted foot only if it is above knee, only if the knee is kept in 90 degrees of flexion. So a good cast will be groin to toe, will have 90-degree flexion of the knee, will have good molding of the areas around the medial malleolus, the lateral malleolus, above the heel, all around. It will support the toes, but it will prevent crowding of the toes. You don't hold it like that, crowding the toes. It should spread out the toes evenly so that there is no crowding of toes. And a good cast will have no tight constriction bands. And a good cast will not be too loose, will not be too light. It has to be a firm cast. Not too much of cotton, not too little cotton.